So, in 2016, Wong et al. Was the first one to start PPOS, and it was a very nice concept. We'll go through some slides about PPOS also. So, what exactly the physiology that initially when we don't have a estrogen prime endometrium, in estrogen prime endometrium, progesterone additional will be having a synergistic effect. As we know that small rise of progesterone will have ovulation. But if it is estrogen deficient, as in early follicular phase, when we have low estrogen, then adding progesterone at that particular time will be having an antagonizing effect on the GnRH pulse frequency. So that is why you are suppressing LH throughout the stimulation. It is one of good protocol for patient compliance and even endocrinologically, to have the low LH and having a good fort is what they have a better success with PPOS protocol. But we started this protocol thinking that oocyte donors will be the best people to start the PPOS because less antagonists, less injections, it will be more friendly protocol for them. But the meteorology progesterone acetate of 10 milligram was not sufficient. We monitored LH after day 6 of the stimulation. We found that still the LH is not that suppressed as we are expecting. And then that's why we stopped doing PPOS completely. So everyone was quoting their papers that PPOS is having very good result, but we never achieved because always the LH used to escape. Then in few of the conferences, they said in Indian scenario, it's better to go for meteorology progesterone acetate twice a day rather than only once a day. But still we are not. But recently when in last conference what we attended, Nicholas Polidas presented a very nice paper on PPOS protocol where instead of, if you see a receipt of meteorology progesterone acetate, it is written that there are no human studies available and we really don't know whether it's teratogenic or no. So, and we know that micronized progesterone we use as a pregnancy support also in our early pregnancies. So they came with the concept that instead of going for meteorology progesterone acetate, you go either with micronized progesterone. So they started doing this along with gonadotropin stimulation from day 1 of the stimulation, micronized progesterone every day, 400 milligram tablet you have to take orally. As we know that micronized progesterone is having side effect of having dizziness and lot of sleep. So give this progesterone tablet like in the evening. So capsule sustained 400 milligram every evening in the night. Even on the day of trigger you have to continue. So that will suppress the LH. But again, this is not applicable when we have good responders or PCOS because we are not, they have done this paper in poor responders only. Poseidon group, they have done the study and have achieved very nice results. So recently only, we have started doing this micronized progesterone protocol whenever the AMH is less than 1.5. And it is working beautifully. They are needing stimulation not more than 10 to 11 days. Good LH, the LH is not over suppressed, but it is not going above 5 or 6. So it's maintaining a good LH tone throughout the stimulation. Maturity wise very good. So what we have observed, I have not done many cases to quote it, but whatever cases we have done, even if the fort what we have achieved is very good and the number of matured oocyte, let's say even we have 5 oocyte retrieval, out of them all 5 or 4 are matured. Even the blastocysts, out of 4 we have 3 blastocysts or 2 blastocysts, which is a very good number in those group when we have less than 1.5 AMH. So in Poseidon, this is really working well. But to quote whether it will be same useful for normal responder or for high responder, we really don't have that experience. But according to Wong et al., even in normal responder, this should work well. But we have not done so far in this case. But PPOS, with meteorology progesterone acetate, we were really not happy. This is only for patients who are having less AMH, which is less than 1.5. We can definitely think of going, because it's cost effective. I can't say cost effective because we are not able to do fresh transfer. It is always has to be a freeze-all when you are going for PPS protocol, but less days of stimulation and a better maturity or better embryo, top quality embryos, we can say. We'll just go ahead with trigger lecture. So we'll just go through the physiology of trigger, and we all aware that the true trigger, what we use commonly is HCG and agonist trigger. We'll talk about dual trigger, failure, and a novel trigger also. So this is the basic slide. So once we are very well versed with this physiology, that how the trigger is working, we can manipulate our trigger whatsoever, either whether she is poor responder, normal responder, or high responder. So what happens in nature? So if you see in nature, this is a natural menstrual cycle, how the LH peak, LH surge, and ovulation will occur. So when we have LH surge. This LH surge is going to be there for 14 hours. The LH peak is going to be there for 14 hours, and by next 48 hours, the LH will go down. So that is how the natural cycle trigger works, and this is at LH peak where the ovulation is going to happen. Now what happens when we have HCG? As we know that HCG is having LH-like activity, it's a longer acting. This HCG will have a high rise of progesterone within next 4 to 6 hours of HCG, and this HCG will be there in blood circulation for almost 6 to 7 days. So that is why HCG is a long acting trigger. When it comes to agonist, in agonist, the GnRH agonist trigger, after 4 hours of GnRH agonist trigger, the LH level peaks. After 4 hours, the LH level drops down, and within next 24 hours, the LH has baseline. And that is why agonist trigger is very short acting, crash luteolysis, because LH is coming down within next 24 hours, and we are seeing, because of the crash luteolysis, a severe luteal phase defect will be there. Now, whenever we are measuring the trigger, why we are not, I'll come to the triggering measuring later on. What is the ideal trigger we should have? This is a kiss peptine, which will act almost like our natural trigger, where it will peak in next 2 hours, and it will be baseline. But we are not having kiss peptine molecule as a trigger in our population. Now, why trigger is important? So as we know that in antagonists we are suppressing for premature luteinization, or either in PPS our main aim is to prevent the premature luteinization of the follicles, because those are asynchronous growth at the end of trigger. Then there are 2 things what we are looking at with the trigger. Mainly is a maturation, and this maturation has to be a cytoplasmic maturation as well as nuclear maturation. So nuclear maturation, as we know, when the meiosis 2 is completed and the polar body appears, that means meiosis 2 is completed and the maturation of the follicle from nuclear point of view is completed. So when we have LH, there should be a 5% of LH rise for maturation of the follicle, but for the ovulation, 85% of LH rise should be there. So in a simple terminology, LH should be of 15 to 18 MIU for maturation of the follicle. So at the time the follicle may get luteinized, but ovulation will happen when the LH level is beyond 60 to 80 MIU. So resumption of meiosis and follicular rupture begins 18 hours and 34 to 36 hours after the onset of LH surge. And amplitude of LH rise decides maturation and ovulation of the follicle. So duration of LH completes the luteinization of all follicles, of all granular cells, and it will lutein that follicle, and decides the adequacy of luteal phase along with the luteinization of the granular cells in the follicle. This is a very beautiful paper, and it is almost 18 to 20 pages paper where they have described very beautifully about the endocrinology of trigger and the novel concept of inducing the final oocyte maturation in IVF treatment. So definitely everybody should read this paper, where they have beautifully explained what is nuclear maturation, what is cytoplasmic maturation. Nuclear maturation, I just told you that once the meiosis is getting completed, the polar body appears, then from meiosis 1 it is meiosis 2. And cytoplasmic maturation is nothing but the arrangement of the organelles, and the mitochondria, the chromatin dispersion. When it is getting completed, that is nothing but a cytoplasmic maturation. Every time we have just focused upon the nuclear maturation of the follicle, but then same way we have to weigh about cytoplasmic maturation also. Why it is important? Whenever in a natural cycle, whenever there is LH surge, at the LH surge there is FSH nick. This FSH nick is very important from the cytoplasmic maturation point of view. This FSH nick, what is going to do? It is going to have the adequate LH receptor on the granular cell layer and the synthesis of hyaluronic acid matrix, which facilitate the expansion and dispersion of cumulus cell and allowing the oocyte cumulus cell mass to float freely in the antral fluid. So this FSH nick, because your LH, LH peak or LH surge will mature the follicle, and for that you should have more LH receptor on the granular cells of that particular follicle. If that LH receptor is not adequate, then even you have a very good LH activity, that maturation of the follicle is not going to get complete. So for that we need FSH, and this FSH nick is going to have more LH receptor on the granular cells, and it will actually release that COC complex from the antral follicle, which will float inside the antral fluid for the ovulation to happen. And this is very important. And this will also tighten the gap junctions of the follicle, the gamma cell layer, and that will push lot of nutrition to the COC. And that is why FSH NIC is physiologically very important for cytoplasmic maturation of the follicle. And this, at the time of FSH NIC, there is slight rise in the progesterone also before LH peak, and this progesterone synthesis facilitate the positive feedback of E2 to induce mid-cycle FSH peak. So nature has synchronized very beautifully. So initially the LH, because you have a dominant follicle, your estrogen on the higher side, that will increase the LH. But the LH surge to happen and to maintain it for a longer time, you need this FSH and progesterone NIC to have more, that to maintain that LH peak for the longer time for maturation of the follicle. And cytoplasmic maturation, FSH NIC is very important. So if we have to choose a trigger, what is the best trigger is agonist trigger. It's a more physiological trigger, because HCG is going to increase only LH-like activity. But if you give agonist trigger along with LH, there is FSH increase, and that is important for the cytoplasmic or good maturation of the follicle. This yesterday sir was describing that why we should know, when in FET also I'm going to have this slide, that whenever we are giving trigger, at the time when the blastocyst is going to arrive, that time your HCG, which is going to be there for activity for 6 to 5 days, at the time of arrival of the blastocyst only, there is a luteal hole, and that phase is not supported whenever we are giving trigger. That is why every trigger to be supported in for a luteal phase, because it may create a luteal phase defect post trigger. So it is a paradoxical thing that when we need a lot at the time of implantation, our protocol after giving trigger will have that luteal phase deficient, and that is why trigger should be followed by luteal phase support. So we will go with what trigger we should have in ovulation induction. Yesterday we have already discussed about ovulation induction agent and trigger, but whatsoever, there are no literature published about trigger criteria in ovulation induction with ovulation induction agents. Whatever we are saying that for letrozole you wait for 19-20 millimeter is all with the maturity of the the follicle will have with letrozole or clomiphene. And there are conflicting results in regards to the optimal size of the lead follicle, when it comes to pregnancy outcome in IUI cycle. So it depends on age of the patient, number of the follicles, and we have yesterday discussed that if you have catch the follicle younger rather than follicle getting luteinized and you facing unruptured follicle syndrome. So when you have a young lady, you have a more than 60 millimeter of the follicle and endometrium is nice triple line which is beyond 6.5 millimeter, you can still give a trigger. If the endometrial thickness is on the lower side, you wait till the follicle goes till 19 millimeter, then observe the endometrial thickness, it is going beyond 6.5 millimeter, you can go ahead with trigger. For advanced age, as we said that there can be premature ovulation, so even start monitoring in patients with advanced age on day 8 of the follicle tracking, and that time even the follicle is 16 millimeter, go ahead with trigger rather than waiting for longer time. So once the lead follicle is more than 16 millimeter, trigger irrespective of endometrial thickness, because these patients are having gonadotropin surge attenuating deficiency, so they may have LH surge but not LH peak, and the follicles get luteinized but not ovulated. If thin endometrium is there, then you can wait and just see in the mid-luteal phase, whatever we discussed yesterday, same thing. So decision making in IUI, this paper I have done yesterday, so I won't go into detail of that. Just remember that even if the patient is having spontaneous LH surge, give trigger and do IUI within 24 hours. The optimal lead follicle size 16 to 18 millimeter. Don't wait to go beyond 19 to 20 millimeter. Catch the follicle younger and you still will be having a better result in patients when we are taking them for IUI with trigger. About thin ET also we have discussed. Now directly we'll talk about HCG, and we know that we have using HCG since long time, and HCG started with long agonist protocol where yesterday in physiology sir was mentioning that potency wise agonist is more potent. If there is HCG is going to be having a long acting action in related to the trigger, but when you are doing a long agonist protocol, we don't have any choice but to go for HCG, because the agonist you are giving continuously, there are no receptor and agonist trigger is not going to have. So even in patients with high response or in PCOS, in long agonist protocol, we can't give agonist trigger and we have to go for HCG trigger. But what we are more fearing in HCG trigger is of hyperstimulation risk. So in HCG trigger, we know that it is not exactly a LH, but it is having LH-like activity. So it will act on the LH receptor, and it binds to LH receptor which is immobile, while the natural LH bind to the LH receptor which are rotationally mobile, and that's why HCG, when it's bind to immobile receptor, it is a long-acting action, and with LH, the action will wear off within 48 hours. So HCG is having 5-fold higher affinity to LH receptor than LH itself, and HCG is more steroidogenic cyclic AMP pathway, and it supports early pregnancy. So by having more progesterone production, while LH will act with anti-apoptotic ERK1 and ERK2 pathway, which is responsible for proliferation, differentiation, and survival of granular cells, and that will have a different impact altogether for the maturation of the follicle. Now, whether there is any difference between giving rHCG or like recombinant HCG or urinary HCG. So Drizos et al. In 2000, the first one to have comparison of rHCG with urinary HCG. No difference in terms of number of oocytes, number of mature oocytes, number of embryos. You have choice of either giving recombinant HCG or urinary HCG. Chinese, like Chang et al. Has done study on 297 patients, same that both the HCGs are better, but all these paper, they have not mentioned what we should do in high BMI. As I mentioned yesterday, that if you are giving HCG trigger, better to go for 10,000 IU and deep intramuscular rather than just taking 5,000, because it may not have, the failure of trigger could be because of the inadequacy of HCG giving in high BMI patient. In Cochrane also in 2016 has said that there is no difference between rHCG and urinary HCG. Then what dose of urinary HCG we should give to say that the maturity can be assured? So 5,000 IU of HCG is good enough where it is raising the HCG beyond 100, and that is adequate for the maturation of the follicle. So oocyte yield did not increase beyond 5,000 IU dose. So standardized you can give 5,000 IU, but if patient is of high BMI, instead of 5,000 you can go for 10,000 IU of HCG intramuscularly. Only fear what we have in HCG is because of OHSS, and this is mainly because of not your high estriol, but because of the VEGF. The high responder can be yesterday somebody was discussing that with very small follicle the patient went into OHSS. So this is the sensitivity of that particular patient, that for this certain amount of HCG, the follicles are producing, the luteinized granular cells are producing maximum amount of VEGF, and this VEGF production is going to have third space accumulation, and the patient can land up into OHSS. As HCG is long acting, and if she has conceived either in IUI cycle or a fresh embryo transfer, adding the HCG of pregnancy will worsen the OHSS. So first is because of your trigger, and second is because of the late onset, which is because of the pregnancy, and that will make the OHSS worse. And this is the culprit is being HCG, which is long acting. So rapid fall in LH levels in 14 to 24 hours happens in agonist trigger, and that is why agonist is based in this scenario where it is a high response or in PCOS patient. So, but the only problem that with agonist trigger you can't do fresh embryo transfer because of the severe luteal phase defect. So whether the HCG level following ovulatory women, whether they have any association with patient weight and implantation time. So this was nice paper which talks about the oocyte maturation rate varies with serum HCG on the morning after administration. So 68% with 20 to 30 IU, 71% with 30 to 40 IU, and 79% with 50 IU or more. So whenever you have very high BMI patient, it's better that if you are giving a shorter dose, small dose with with not short needle, then it may happen that the adequate trigger is not work in this patient, and inadequate though you had given HCG trigger can fail. As such, the HCG trigger failure is very, very low. It is less than 1 to 2%, but it is morely in patients with high BMI. So in high BMI, if you are giving, it is 10,000 IU with deep intramuscular urinary HCG. If it is rHCG, then you give 500 microgram subcutaneously. Whether the HCG trigger is measurable, it's not a common practice. So initially, on the day of ovum pickup, when you are giving only HCG trigger, we used to do urine pregnancy test to see whether the trigger has worked or not. But failure of HCG trigger is very, very low. So no longer it is practice, but we can measure the trigger on the day of ovum pickup. Whether it is reliable, definitely, because we are using since log omics protocol, and it has given good results over a decade. Whether it is safe, big no when a patient is PCOS or high responder because of OHSS. Clinical outcome, yes, good clinical outcome, because all of us have enjoyed pregnancy with long agonist protocol, and there are many studies been published that HCG trigger will act very well when it comes to pregnancy outcome. When HCG trigger can fail, this is we already discussed about high BMI and root. Now with agonist trigger, we have lupride, we have decapeptyl, bisrelin, nasal 100 microgram nephrine. It is not available in India, but decapeptyl and lupride is what commonly we use in our practice. Now, as we are discussing that agonist trigger was very well criticized initially, thinking that it is having a crash luteolysis and fresh embryo transfer is not going to give good result. So in this 2023 paper, Peter Humaydan has nicely he has described about the story of GnRH. So there was a Dutch poet who has nice poetry about the ugly duckling. So initially he was in the group of swan. So he was being outcasted because he was being a duck. And he went, because of the outcasting, he was very low, and he went to place to place till the time he found a flock of swan, and then they welcomed him. When he saw his picture in the water, then he realized, I am not a swan, but I am a duckling. So they actually welcome him. The same thing has happened to the agonist trigger, that initially it was been very criticized that it is not giving good effect with GnRH agonist trigger because of the crash luteolysis. But the FSH NIC, which is very important for the maturation of the follicle, will be given by GnRH agonist trigger, and that is why the GnRH agonist trigger is more physiological compared to the HCG trigger has been proven. The only drawback, fresh embryo transfer can't be entertained. So initially, Peter Humaydan and Kolibenkis, these are the first authors who started doing fresh embryo transfer in spite of giving agonist trigger in patients who are high responders. And they have to abandon the study. With fresh embryo transfer, they have clinical pregnancy rate of less than 5% and very high miscarriage rate of 79%. So they actually stopped this publication because they were not giving good result. But both of these authors met in one conference and then discussed that we have failed with our first publication because there are very negative results and high miscarriage rate. But when we talk about the cumulative pregnancy rate, we have surplus amount of embryos because we have used this trigger obviously in patient with high responder, and very top quality embryos were there. So it is not about the embryo quality, it is about the endometrial receptivity, and that is why the result in freshity was been on the lower side. So now they came with a concept that this poor outcome is because of the not in the defect of follicular maturation, but or impairment of the embryo. It is mainly because of the endometrial defect. And they thought that instead, even if we are going for fresh embryo transfer, let's support the luteal phase in intensified way. So they came with a terminology called intensified luteal phase support after giving agonist trigger. And both of them have done this fresh embryo transfer after agonist trigger in two different ways. Humaydan done with intensified luteal phase support with small HCG dose 1500 IU on the day of oocyte retrieval, and again on the day of blastocyst transfer. So fresh embryo transfer, but on today on the day of trigger, they had given agonist trigger. On the day of oocyte retrieval, they had given 1500 IU of HCG. And again on the day of transfer, on the day of blastocyst transfer, they had given 1500 IU of HCG. And they found that the numbers were better compared to what they have faced. But still, the miscarriage rate was 28 to 30%, and the pregnancy rate was 30 to 40%. And obviously, they had given not severe OHSS, but moderate OHSS was very common in this particular study. With Engman et al., they had given intensified luteal phase support. So instead of giving HCG, they had given intramuscular progesterone and estradiol as intensified luteal phase support. So you are maintaining a good progesterone level, that is maintaining the luteal phase support. And they found the results are still better. But again, the OHSS is very difficult to predict, and for that reason, fresh embryo transfer is not acceptable or won't give a good result when we agonist trigger in high responder. So no in IUI cycle due to luteolysis, you will induce earlier periods as well. Only with multiple follicles, as we were discussing yesterday, that modified lupride trigger, you can go ahead with lupride trigger in IUI. Now this is when whether the agonist trigger is measurable, and as we discussed that LH will be there, rise will be there in 4 hours. By next 20 hours, the LH will come down. So the action will be completed in 24 hours. Now, if at all our all trigger goes in the night, if at all we have to maintain the ideal time to measure the trigger after giving agonist is 4 hours after the trigger. But then you have to keep patient admitted, because let's say you are given at 11 o'clock, you have to measure the trigger around 3 o'clock and patient needs to be admitted. Then where we measure the trigger is after 12 hours, where the LH has peaked in next 4 hours, but now LH is the downfall and progesterone is rising. So we measure the trigger where the LH is on the downfall trend and the progesterone on the higher side. So 12 hours measure trigger. So what generally we practice that, let's say this patient is of PCOS or high responder, where we are suspecting that we'll be getting more than 15 oocyte at the time of oocyte retrieval, then we give agonist trigger. Let's say we are given agonist trigger now, then after agonist trigger at 11 p.m. in the night, then tomorrow morning 11 o'clock we'll measure the trigger. So today on the day of trigger we are done. E2 we do just like, as we mentioned that what is the follicular output and whether we are correlating. Along with that, we'll do LH and progesterone level on the day of trigger, and we'll measure the trigger, the same LH and progesterone level post trigger 12 hours later. Then what should be the value of this LH and progesterone after 12 hours? So your LH should be more than 15 and progesterone should be more than 3.5, but what we cut off we take is 5.5. So progesterone more than 5.5 and LH more than 15 will tell you the adequacy of the trigger, whether the trigger has worked or not. So these are the beautiful paper about adequacy of generation agonist trigger for oocyte maturation and management of inadequate response. So LH less than 15 MIU was associated with no or very less oocyte retrieval. Progesterone level is complementary to LH. Higher the number of follicles, more is the progesterone. So progesterone level above 5.5 and LH level below 15, they can obtain good oocyte, but low progesterone with high LH cannot. Why it is so? Because we are measuring a trajectory where LH is going down and your progesterone is rising. So after 12 hours, you may have LH level of 20 or 25, but your progesterone level is 8. Don't worry, the trigger has still worked. But LH value, the progesterone value is, LH value is around 40, but your progesterone value is only 3. Then you have to again think twice that this trigger may not work, because you are measuring a trajectory after 12 hours. So progesterone is more measurable, and that will give adequacy of trigger rather than only LH increase. Now, whether the agonist trigger can fail? Yes, almost in 3 to 5% of the patient, the agonist trigger can fail, and where it is LH less than 15 and progesterone less than 5.5. Then what we fear in agonist trigger, what mean by failure of trigger? Means the maturity is not completed and the chances of empty follicle syndrome or low follicular output is very, very high in patients if the trigger has not worked. Then what is the suboptimal oocyte yield if you are giving agonist trigger, and in which patients it can happen? It can happen in a patient where there is low or very high BMI, very basal LH level. Like since the beginning we are saying again same thing, that start your stimulation with good LH pool. Unless or until your LH is beyond 2 MI, you don't start, because if you are starting with very low LH, then you may face empty follicular syndrome. Start day LH level if it is less than 1.2. Low trigger day LH, sir was describing in last lecture that on the day of adding antagonist or on the day of trigger, if LH is very, very low, then we may fear that our oocyte yield can suffer. In patient with prolonged stimulation, because the oocyte sensitivity in this particular patient is very, very low, and that can suffer the outcome. High FSH dosing, long OC pills where your again hypothalamic pituitary ovarian axis is suppressed and you are again starting with very low LH pool. And patient with hypoc. Yesterday we have discussed this topic about hypoc. It's better that if you are giving agonist trigger, you should have a gas test, and then only you can think whether you have to give agonist trigger or HCG trigger. Empty follicular syndrome could be the genuine empty follicular syndrome, whether it is exist or not, it is very, very rare. It is less than 1% genuine follicular syndrome. What we come across is a false follicular, empty follicular syndrome, and it could be because of inadequate LH trigger. Immature oocytes have dense cumulus, hence difficult to retrieve. False empty follicular syndrome, that can happen if there is error in triggering dose. If you are giving trigger for an obese patient and it has not in an adequate manner. genuine follicular syndrome, it is hormonal response is detected, but oocytes are still not mature. Means you have measured the trigger and you know that the trigger has worked well, but still you are not getting adequate oocyte. And this could be because of some genetic mutation for the follicular genesis of that particular follicle apparatus, and that is why the follicle is failed to have a maturity. The HCG or LH value where you will have empty follicular syndrome is not defined, and we lack that information that what LH and HCG value we should look to see that to predict that we may face empty follicular syndrome. Now dual or double trigger. Dual trigger is giving your HCG trigger and agonist trigger simultaneously at the same time, and double trigger means you are giving your agonist trigger at 40 hours and HCG trigger as 34 hours. Now whatever in our practice, when it is high responder or when it is PCOS, when we are expecting more than 15 oocytes at a time of oocyte retrieval, always we give agonist trigger. But there is a normal responder or it's a poor responder, our trigger is always dual trigger and not alone with HCG trigger, because we want that FSH nick from the agonist trigger which will have a better maturation rather than giving only HCG trigger. So dual trigger in patients with normal responder or poor responder. Ding et al. Was in 2017 published a meta-analysis in dual trigger versus HCG trigger alone in 527 women. He found that there is no difference in oocyte number, maturation, fertilization rate, but pregnancy rates are more when the double trigger was being given, and the relative risk was 1.55, and if you see the confidence interval, it is between 1.17 to 2.06. So addition of LH FSH means agonist plus HCG showed higher activation of steroidogenesis and maturation compared to alone HCG trigger. Now, when we can say that there is a low oocyte yield, and it is defined by the ratio of number of oocyte received divided by the number of follicles beyond 14 millimeter on the day of trigger. Means whatever, let's say you are on the day of trigger, you have 20 follicles, but you retrieved only 8 follicles. Now it is less than 50%. That is what is the low oocyte yield or suboptimal oocyte yield. So in this particular patient, this was a retrospective study. Always, whatever the published studies are there about double trigger, they're retrospective, because in first cycle, nobody will suspect that this patient will be having failure with either dual trigger or with agonist trigger, if at all it is acted well. So then they came with the concept of giving double trigger, where the maturity in some patients, when we are describing that there could be few group of a patient because of the some genetic mutation in the follicle apparatus, when we think the maturation has to happen within 35 to 36 hours of giving trigger, they will be having a delayed ovulation. But very difficult to predict in first cycle itself, where your oocyte yield has suffered in spite you measuring a trigger, and still your oocyte yield is suboptimal. In this patient, what they have done, they had given double trigger if there was a suboptimal oocyte yield in the previous cycle. Then they gave 34 hours, 40 hours they had given agonist trigger, and 34 hours later they had given HCG trigger, and double trigger in women with initial low oocyte yield. The maturation was 70% compared to 47% in the previous cycle, and the pregnancy rate was 50% and compared to the previous cycle, which was 0%. So they found that very good maturity in this particular patient, and this mainly for the follicular apparatus, where we really not able to pinpoint a reason that why this particular patient failed in spite of giving adequate trigger. So there are many studies been published. Again, when we combine and see whether which trigger is better, the double trigger will act as always have an additional effect rather than only going with alone HCG trigger. Now, this was the same paper which talk about giving double trigger specifically in patients where there is low response. So co-administration of GnRH agonist and HCG trigger for final oocyte maturation, and they have found it increases top quality embryos and number of oocytes. So what they have done, they have studied the first cycle. Whenever in first cycle they got less than 3 top quality embryos, then next cycle instead of giving dual or only agonist trigger, they had decided to go for double trigger, and they found that higher CLBR, that is 20% versus 2.86% in this particular group. Even the CLBR and cumulative persistent pregnancy rate were higher when they had given double trigger. So what we are doing with double trigger, we are prolonging the time between ovulation triggering and ovum pickup, and GnRH trigger with the consequent simultaneous induction of FSH surge. The double trigger, you are giving agonist trigger first at 40 hours. that is going to have a more and more LH receptor induction at that particular time because of the agonist trigger. After 4 hours of that, you are giving HCG trigger, which is now will act very well, and that is why you are prolonging the time between agonist trigger and your oocyte retrieval. That will have good effect in patients where there is an existing impairment in granular cell function, oocyte meiotic maturation, or cumulus expansion. Very difficult to find out and very difficult to have study also in such group of patients that why particularly they are having impairment in the granular cell function or maturation. This was recently only very nice paper by Rollo Orevito 2025 that triggering the final maturation and appropriateness of which trigger we have to give in which patient subgroup. So I'll just go to this slide directly. So there, she has divided this trigger into high responder, normal responder, and abnormal oocyte maturation, and poor responder. High responder, we know we don't want to take chance, we'll give agonist trigger only. Then later on, you can think if you want to go for intensified luteal phase and still go ahead with fresh embryo transfer with the risk of OHSS in mind. Normal responder, as we discussed, that dual trigger will act well, where the adequacy of the trigger and maturation will be better. In poor responder, we have two choices: either give at 40 hours agonist trigger, and then you give HCG trigger at 40 hours, and then you go for ovum pickup, or you can give both dual trigger in poor responder at simultaneously. So what is the difference? What is the difference he has given here clearly? That whenever you are given dual trigger, now there could be on the day of trigger, you can be having two scenarios. There are follicles which are beyond 17 millimeter, and there are follicles which are less than 17 millimeter. So dual trigger 34 hours before ovum pickup, when the leading follicle reaches more than 17 millimeter in diameter. Because what everybody of us is fearing, that we don't want premature ovulation and we want a proper maturation of the follicle. So whenever you have more than 17 millimeter follicle on the day of trigger, that time instead of giving trigger late, you can give at 34 hours. You can give do the ovum pickup at 34 hours rather than 36 hours, so that there will be a less risk of premature ovulation. The double trigger, when the leading follicle reaches less than 17 millimeter diameter on the day of trigger. So you can divide into two groups. On the day of trigger, you have a follicle which is less than 17 millimeter. Then instead of giving dual trigger, you go for double trigger. So giving 34 hours, 40 hours agonist and HCG at 34 hours. But if the follicle is already 17 millimeter, with the fear of premature ovulation, you give dual trigger, but do ovum pickup at 34 hours. So with that, you will be having a better maturation, and suboptimal oocyte yield can be prevented in this particular group. Now about follicle size of the trigger, we have many times we have discussed. When it comes to IVF stimulation and follicle size at the trigger, small follicles and large follicles have less oocyte yield. Means you have a follicle which is less than 14 millimeter, we may have less oocyte yield from that particular follicle. At follicle beyond 24 millimeter, so more than 3 follicles of more than 17-18 millimeter, that was the criteria borrowed from long agonist protocol. But what we practice in antagonist protocol, that maximum herd of the follicle which is beyond 17 millimeter, then we give trigger. Dubey et al. 16 to 20 millimeter follicle has better fertilization rate, and 22 millimeter follicle has a fertilization rate of 73.9%. So you can give trigger from 16 millimeter to 22 millimeter when you have a larger cohort in that particular group. So 16 to 22 millimeter have the best maturation and fertilization rate, and then you can decide the trigger criteria during your IVF stimulation depending on the follicle size. Now you may have a scenario where you had given agonist trigger and you have measured the trigger. Means you had given agonist trigger in high responder in thinking of OHSS, and you measure the trigger after 12 hours and you find that the progesterone is less than 5 and your LH is on the lower side. Then what is our next? You have all the time thinking that she may have OHSS, and that's why you had given preferred choice of agonist trigger. Now you have to counsel the patient in front of you that this trigger has not worked. So if you do OPU tomorrow, we are going to have either empty follicle syndrome, like empty follicles, or we'll be having a very suboptimal oocyte yield. So the other option is to go for HCG trigger today, but the fear of OHS is going to be still there. But now we know that we may have OHSS later, then we will manage post-trigger OHS, post-ovum pickup OHSS, rather than suffering with the suboptimal oocyte yield or empty follicle syndrome. Recently, like last 6 months back, not with us, one of the student has asked about this query, that the progesterone level after 12 hours of trigger was only 2. And that's why we said, like, the LH is also on the lower side, the trigger has not worked well. So after proper consent and discussing with the patient of risk of OHSS, that what we are advised that give HCG trigger today. Let's say again you have to give and night, and you have to do pick after 35 hours only. Though we have that risk of premature ovulation, but we have to take that risk. What you can give after post-trigger, give Brufen and do ovum pickup of 35 hours. And they found that initially when the trigger has not worked, and later on when they went ahead with ovum pickup, they got 18 oocytes. Out of them, 13 were matured. So this is very, very rare scenario. Like, I still not have come across where the agonist trigger has failed. But this can be a scenario. So whenever we have agonist trigger, it's better to measure rather than facing suboptimal oocyte yield or empty follicular syndrome. Then in PPOS, in last lecture, sir was mentioning about when we are doing PPOS, then there could be a question mark about maturity of the follicle. So this was paper published in 2023, that there could be a delayed ovulation in PPOS because you are giving progesterone since beginning, that actually downregulate this LHCGR and progesterone receptor pathway like too much, and this PPOS which inhibit LH level and this LHCGR expression on the pre-ovulatory follicle before trigger. This takes time. As we discussed, we need to have more LH receptor on the follicle for the trigger to act. Now because of the PPOS, this is too much suppressed, and this progesterone synthesis and progesterone expression reduces 4 to 6 hours after HCG. So the ovulatory genes are regulated by progesterone receptors are down regulated, and this delays the ovulation at 12.5 hours after the trigger. So whenever you are following a PPOS protocol, like you delay your trigger time, you delay your pickup time. So let's say you had given trigger at 11 o'clock, instead of doing your pickup at 9:30, 10, it's better to do post 11 or around 36 to 37 hours rather than doing it before, because the maturity of the follicle should not suffer. And in PPOS protocol, that will take some time to get mature because of the LHCGR expression is too much suppressed. So PPOS has delayed follicle wall degradation, VEGF, protease cumulus expansion, all is affected. So whenever you are doing OPU, trigger time delays by 36 to 37 hours and has better mature oocyte compared to doing the pickup at 35 hours. Whether we can give double trigger in IUI cycle or whether it will improve the result. So this was study which is done in 639 IUI cycles, retrospective study, and they found that giving dual trigger will be having better result in terms of IUI. But IUI result is going to be between 15 to 18% only. So in our practice, we don't give dual trigger as such. What we practice if we have more follicles is about modified Lupride trigger. I don't know, somehow I missed that thing, but I'll just go to another slide. And this was about modified Lupride trigger. So when we have more than 3 follicles recruited, risk of OHSS versus cancellation of the cycle. So then generalized trigger is at rescue. If you give generalized agonist trigger as the way we are giving it for our IVF stimulation, it will cause crash luteolysis and decrease the chance of pregnancy. So agonist trigger 12 hourly 3 doses with the novel trigger of modified Lupride trigger. When we have more than 3 follicles of more than 17 millimeter, the first dose 1.5 ml, second dose 12 hours later of first dose, that is 1.5 ml, and third dose 12 hours of second dose later, and 1 ml. So divide trigger 12 hourly, 1.5, 1.5 and 1 ml. And the physiology behind that, you are maintaining a continuous LH tone, that every your agonist trigger is going to have that flare effect, and that will maintain the LH level. Do IUI 35 hours later of first dose, and luteal phase support with dydrogesterone is not measured as serum progesterone, as I was mentioning yesterday, that we are doing this mid-luteal progesterone level, and this mid-luteal progesterone is very well maintained in spite of giving oral progesterone. We are not purposely giving vaginal progesterone because we don't want it as a surrogate marker of serum progesterone, but very well maintained progesterone level. So this is a novel protocol which, instead of like cancelling the cycle, we had given in patients who are not high responder or PCOS, in normal responder or in poor responder, when we have 3 to 4 follicles also, we had given this trigger, but none of the patient had OHSS, and this trigger has worked in pregnancy rate as par with your SV trigger. So no harm rather than cancelling the cycle. Do think about this novel trigger in your practice, so that you will have less cancellation and still you will be having a better pregnancy rate with whatever protocol you are following. Thank you so much.